Yeah, unloading is a fundamental principle. It's a physiologic principle, and by its most simplest definition is that LV unloading refers to reduction of LV pressure and volume, which leads to a reduction in left ventricular wall stress. And we can do that through pharmacologic methods, and we can through device-based methods. And so that's the fundamental concept of LV unloading. Yeah, the DTU-STEMI trial is based on 4 decades of experience with heart attack therapy. And what we've learned over the years is that heart attacks lead to heart failure. And as a result, the major determinant of whether or not you're going to develop heart failure after a heart attack is the size of the infarct and how much myocardial damage occurs. And so in contemporary practice, our only approach to reducing infarct size is to reperfuse the artery, and that is the fundamental door-to-balloon time built on the open artery hypothesis. And this concept is one that has helped us reduce mortality rates substantially by reducing door-to-balloon times. But now, in the contemporary era, we're seeing that door-to-balloon times are reduced very significantly. We're well below 90 minutes. And what we're seeing is that for every 5% increase in the size of the infarct, that's associated with a 20% increase in your likelihood of developing heart failure at 1 year or having a mortality at 1 year. So the door-to-unload STEMI trial is taking advantage of 4 decades of engineering in the field of mechanical circulatory support, where we now have percutaneously delivered devices that can effectively unload the ventricle and, as a result, reduce myocardial oxygen consumption in the setting of a heart attack. And based on about 3 decades of preclinical work, we've learned that if you put in an LV unloading device before reperfusion in a heart attack in these preclinical models, you can significantly reduce infarct size. So the door-to-unload STEMI trial is the first trial to implement a transvalvular pump known as the Impella device, which is a widely available, accepted device for the use of LV unloading. And the DTU-STEMI tests the concept of loading with the Impella device before reperfusion in the setting of a heart attack. Now, the wrinkle of the door-to-unload STEMI trial, what makes it even more disruptive, is that the preclinical data showed that not only do you need to put in the pump before reperfusion, but actually the most efficient way and the most effective way to reduce the infarct size is to put in the pump and wait 30 minutes before opening the artery. And that really is a new paradigm shift, because what it forces interventionalists to do now is to focus on the ventricle before focusing on the coronary vessel in the middle of a STEMI heart attack. So the door-to-unload safety feasibility pilot study is a phase 1 safety feasibility study with a 1-to-1 randomization of patients to 2 arms, LV unloading followed by immediate reperfusion, or LV unloading followed by a 30-minute delay to reperfusion. And the purpose of the study was to answer this question based on the preclinical work: how important is that delay? First of all, is the delay feasible? Is it safe? And then does it actually lead to any early signs of efficacy? What can we learn from a pilot to help design the pivotal study? And so the door-to-unload STEMI study was completed in April enrollment. The first criteria for feasibility was, could we actually complete the study? Did we have protocol adherence? And the second output of the study was 30-day MACE, looking at major adverse cardiovascular and cerebral events. And then the third output was to look at a comparator of infarct size. We all believe in the fundamental concept that time is muscle. And if we delay reperfusion, even on the platform of unloading, it was very important for us to answer whether or not that leads to an increase in infarct compared to unloading an immediate reperfusion. And those were the quantification of the myocardial damage was by cardiac MRI or CMR at 3 to 5 days and as well as 30 days after the ST elevation presentation. Yeah, so we're very pleased to have completed the pilot. What we learned from the pilot, first of all, is that it is safe, it is feasible to unload the ventricle using an Impella platform and to delay reperfusion. And I say that because what we saw was that overall 30-day MACE was low in the study. We also saw that there was no significant increase in infarct size on the platform of LV unloading, even with a 30-minute delay to reperfusion. And I think that's one of the more fundamental concepts to take away from the study. There were a number of nuances to the study which were important. First of all, we saw that operator behavior really suggested that patients were well supported on the Impella platform during that 30-minute delay. And I say that primarily because we had 0 bailout from the unload and delay arm to the unload and immediate reperfusion arm. And then there was an exploratory subgroup analysis, which was provocative, which was interesting, and what that demonstrated was that amongst patients who had the largest ST elevation MI, we found that there was a statistically significant reduction in infarct size with unloading and delayed reperfusion compared to unloading and immediate reperfusion. And that exploratory subgroup analysis is that early efficacy signal which helps us think about how to design the pivotal study. So I think, first of all, for clinical practice, as you said, it's a pilot study. I think that's critically important. The Impella device is widely available worldwide, and as a result, it's indicated for cardiogenic shock and high-risk PCI. It is currently not indicated for ST elevation MI without cardiogenic shock. So I don't anticipate that the immediate results of the door-to-unload pilot study will change the way operators behave currently. But what it will do is it will change how operators think about LV unloading and how they think about STEMI management. And I think that's really the most important takeaway from the door-to-unload pilot, is that we, for the first time, have now tested that it is safe and feasible to think about the ventricle first in the setting of a heart attack. And also, we now have an early efficacy signal for the pivotal. So the pivotal study will now, instead of having 3 arms, which would be a standard of care for STEMI or heart attack management, and having 2 additional arms of unload and immediate versus unload and delay, the pivotal study will now have 2 arms, which will be standard of care for anterior ST elevation MI without cardiogenic shock, compared to LV unloading with the Impella platform, followed by 30 minutes of delayed reperfusion for the pivotal design.